Welcome to the image analysis for the humerus. We're going to talk about the common projections of the AP and lateral humerus projection. We're also going to talk about common positioning errors and ways to take corrective measures. Let's start with the AP projection of the humerus. Image analysis guidelines for the humerus AP projection state that the distal humerus, medial and lateral humeral epicondyles should be demonstrated in profile. 1/8 of the radial head should superimpose the ulna. For the proximal portion of the humerus, the greater tubercle is demonstrated in profile laterally. The humeral head is demonstrated in profile medially. The lesser tubercle is visible but halfway between the greater tubercle and the humeral head. The humeral midpoint is at the center of the exposure field. The shoulder and elbow joints and the lateral humeral soft tissue are all included within the exposure field. Here are those image analysis guidelines for your review. In an AP projection of the humerus, proper rotation is key to accurately demonstrate the anatomic structures. Let's review how to assess external rotation and make the necessary adjustments. When the humeral epicondyles and the greater tuberosity are not clearly demonstrated in profile, we want to assess the relationship between the radial head and the ulna. If less than 1/8 of the radial head is superimposed over the ulna, the humerus has been externally rotated more than necessary. In this case, we would adjust by slightly internally rotating the humerus to achieve that proper alignment. Now, for internal rotation, if more than 1/8 of the radial head superimposes the ulna and the greater tubercle is not in profile laterally, the humerus has not been externally rotated enough. To correct this positioning error, we need to continue rotating the humerus externally until the humeral epicondyles are parallel with the image receptor. By carefully evaluating these anatomic landmarks, you can ensure an optimal AP projection of the humerus, thus improving your diagnostic quality. Go ahead and review this practice analysis of the humerus and answer the following question. Let's review this practice analysis together. As stated before, we want to look at the relationship of the humeral epicondyles and the placement of our greater tubercle and the placement of our radius and ulna to determine whether or not we are positioned in a true AP projection. In this case, the greater tubercle is not demonstrated in profile laterally. By looking at the elbow joint, the epicondyles are not aligned with the IR parallel, and you can see that the radial head is superimposing the ulna by more than 1/8. This should indicate to you that the patient's arm was insufficiently externally rotated. We need to increase that rotation until those epicondyles are parallel with the IR to get your true AP projection of the humerus. Let's move on to the lateral humerus projection. Image analysis guidelines for the lateral projection of the humerus, the proximal humerus, State that the lesser tubercle is demonstrated in profile medially. The humeral head and greater tubercle are superimposed. For the distal humerus, the anterior surfaces of the capitulum and medial trochlea are aligned. The humerus should be at the midpoint or the center of the exposure field. The shoulder and elbow joints and the lateral humeral soft tissue should all be included within the exposure field. Here are those image analysis guidelines for your review. When performing a lateral humerus projection, proper positioning is essential to ensure accurate visualization of the anatomic structures. So let's examine the mediolateral and lateral medial projections and how positioning affects image quality. For the mediolateral projection, the torso is positioned in an upright in a PA projection, with the arm internally rotated until the humeral epicondyles are perpendicular to the IR. It is crucial to maintain the torso in a true PA position. Avoid allowing the patient to rotate towards the affected humerus, as this will increase tissue thickness at the proximal humerus compared to the distal humerus. This variation can lead to higher brightness and lower contrast resolution in that proximal humerus, impacting overall image quality. In the lateral-medial projection, the torso is placed in an AP position, with the arm internally rotated until those humeral epicondyles are perpendicular with the IR. If the forearm is positioned across the body to flex the elbow without sufficient internal rotation, the distal humerus will remain too close to the IR. This misalignment results in the capitulum appearing posterior to the medial trochlea. A distorted proximal forearm will occur, and the lesser tubercle will be in partial profile. Proper internal rotation is necessary to prevent these errors. In the subsequent slides, we will take a better or closer look at that particular positioning error, so you get a little bit of an idea of what that looks like. This projection here is a projection done with accurate positioning. I think it's important to note that for a lateral humerus projection, the central ray is directed to the mid-humeral shaft, approximately 5 inches from the elbow joint. Due to the elbow's distance from the central ray, X-ray beam divergence must be considered. In a medial lateral projection, the medial trochlea is positioned further away from the IR than the capitulum, causing beam divergence to project the medial trochlea distally, as you can see in this projection. Conversely, in a lateral medial projection, the capitulum is farther from the IR, and therefore the beam divergence will project it distally in relation to the medial trochlea. Understanding these positioning principles ensures proper alignment, reduces distortion, and improves overall diagnostic quality. Go ahead and review this positioning practice, and we will review it together. Answer the following question. So let's review this positioning practice. For this lateral projection, the patient was placed in a with their torso in a PA projection. Okay, as you evaluate this image, you can see that there is some increased brightness and reduced overall radiographic contrast resolution over the humeral head. What is happening is that the patient's upper chest tissue and maybe their breast tissue thickness in the upper body is covering that proximal humerus. In order to correct this imaging error, we really need to rotate that torso away from the proximal humerus into a more of a PA projection. Go ahead and review this last practice analysis and answer the following question. So let's analyze this image together. When the lateral medial projection is improperly positioned, there's several key indicators that can be observed. In this case, the capitulum will appear posterior to the medial trochlea. The proximal forearm will look distorted. The lesser tubercle is only partially in profile. All these issues occur due to insufficient internal rotation of the arm, meaning that the humeral epicondyles are not perpendicular to the image receptor. To correct this misalignment, we need to ensure that the distal forearm is properly supported on the image receptor, especially if it was resting on the abdomen. And internally rotate the arm until the humeral epicondyles are perpendicular with the IR. These overall adjustments will improve your image quality. This completes the image analysis for the humerus. If you have any questions, please feel free to reach out to me via email or at clinic. Thank you.